Good morning, everybody. I welcome all the undergraduate students of MR Medical College to yet another session in the Department of Pathology. So, today, myself, Dr. Rajesh Patil, signing in to deal with the topic systemic lupus erythematosus. So, this is yet another important autoimmune disease that we come across in day to day life in our OPDs. So, what do you mean by this? Already we dealt last time in autoimmune diseases. So, this is also one of the important topic that we have to deal with. Not only in clinical setups we come across such cases, but also it's very important when it comes to studies point of view. That is, an important 5 marks question can be given on this particular topic, systemic lupus erythematosus. So, SLE is an autoimmune disease involving multiple organs characterized by a vast array of autoantibodies. So, complete autoantibodies here. What are those important ones? The antinuclear antibodies, ANAs, in which injury is caused mainly by deposition of immune complexes and binding of antibodies to various cells and tissues. Types: chronic discoid lupus erythematosus, subacute cutaneous lupus erythematosus. So, coming to chronic discoid lupus erythematosus, it is characterized by the presence of skin plaques showing varying degrees of edema, erythema, scaliness, follicular plugging, and skin atrophy, surrounded by an elevated erythematous borders. The face and scalp are usually affected, but widely disseminated lesions occasionally occur. The disease is usually confined to the skin, but 5% to 10% of patients with discoid lupus erythematosus develop multi-system manifestations after many years. So, coming to subacute cutaneous lupus erythematosus proper. It's a predominant skin involvement. The skin rash is widespread, superficial, and non scarring, although scarring lesions may occur in some patients. There is a strong association with antibodies, SSA antigen, and with the HLA-DR3 genotype. So, antibodies to these antigens you come across here. Drug induced lupus erythematosus. A lupus erythematosus syndrome may develop in patients receiving a variety of drugs like hydralazine, procainamide, isoniazid, and D-penicillamine. What is the revised criteria for classification of systemic lupus erythematosus? The criterion definition: malar rash, fixed erythema, flat or raised over the malar eminences, tending to spare the nasolabial folds. Discoid rash, erythematous raised patches with adherent keratotic scaling and follicular plugging. Atrophic scarring may occur in older lesions. Photosensitivity, rash as a result of unusual reaction to sunlight by patient history or physician observation. So that's very much noted here, photosensitivity. Oral ulcers, oral or nasopharyngeal ulceration usually painless, observed by a physician. Arthritis, non-erosive arthritis involving 2 or more peripheral joints characterized by tenderness, swelling or effusion. Serositis, pleuritis, convincing history of pleuritic pain or rub heard by effusion or evidence of pleural effusion. So, when there is pleural effusion, the patient has an acute pain. It's a throbbing pain here. I have come across a patient wherein he had a pleural effusion and pleuritis. See, effusion need not cause always pleuritis, but most of the times it may cause. So, whenever there is pleuritis, it's a severe aching pain in the chest. Or pericarditis, documented by electrocardiogram or rub or evidence of pericardial effusion. Renal disorder. Persistent proteinuria, that is more than 0.5 gram per deciliter or greater than 3 if quantification not performed. Cellular casts, maybe RBC cast, granular, tubular, or mixed type of cast that you come across here. Neurological disorders, seizures in the absence of offending drugs or known metabolic derangements. Example, uremia, ketoacidosis, or electrolyte imbalance. Or psychosis in the absence of offending drugs or known metabolic derangements. Uremia, ketoacidosis, or electrolyte imbalance. Hematologic disorder, hemolytic anemia with reticulocytosis, or leukopenia less than 4, that is 4000 cells, or lymphopenia less than 1500 lymphocytes. Thrombocytopenia, so again here the count it goes down than 1 lakh. So there is pancytopenia history can be there. So whenever there is pancytopenia, it's immunocompromised. So usually such SLE patients in this present scenario of COVID are very vulnerable, susceptible. Immunologic disorder, anti-DNA antibody to native DNA in the abnormal titer or anti-SM, presence of antibody to SM nuclear antigen, or positive finding of antiphospholipid antibodies based on an abnormal serum level of IgG or IgM, anticardiolipin antibodies. A positive test for lupus anticoagulant using a standard test, or a false positive serologic test for syphilis known to be positive for at least 6 months and confirmed by negative trypanosoma immobilization or fluorescent trypanosoma antibody absorption test. Antinuclear antibody, an abnormal titer of antinuclear antibody by immunofluorescence or an equivalent assay at any point in time and in the absence of drugs known to be associated with drug-induced lupus syndrome. A person is to have SLE if any 4 or more of the 11 criteria are present. So there are a set of criteria, serially or simultaneously during any period of observation. The hallmark of SLE is the production of autoantibodies. Production of autoantibodies against many antigens is the characteristic feature of SLE, but precise mechanisms underlying B cell hyperreactivity are unknown. Now coming to antinuclear antibodies, ANAs, these are directed against nuclear antigens and can be grouped into 4 categories. Antibodies to DNA, antibodies to histones, antibodies to non-histone proteins bound to RNA, and antibodies to nucleolar antigens. The most widely used method for detecting ANAs is indirect immunofluorescence, which can identify antibodies that bind to a variety of nuclear antigens including DNA, RNA, and proteins, collectively called generic ANAs. The pattern of nuclear fluorescence suggests the type of antibody present in the patient's serum. 4 basic patterns are recognized. Homogeneous or diffuse nuclear staining usually reflects antibodies to chromatin, histones, and occasionally double-stranded DNA. Speckled pattern refers to the presence of uniform or variable-sized speckles. Speckled pattern is seen with antibodies against various nuclear antigens including SM and RNPs. Nucleolar pattern refers to the presence of a few discrete spots of fluorescence within the nucleus and represents antibodies to RNA. Nucleolar pattern is typical of antibodies against nucleolar proteins. So these immunofluorescence are very important when it comes to the staining of these particular DNA patterns. the antibodies. Centromeric patterns. Patients with systemic sclerosis often contain antibodies specific for centromeres. See, a chromosome has arms, okay? So they are basically sister chromatids, or a short arm or a long arm, depending upon the type of chromosomes. That is from 1 to 22 plus 1. So here, at the center, there is a centromere. So which give rise to this particular pattern. So centromeric pattern. The fluorescence patterns are not absolutely specific for the type of antibody and because many autoantibodies may be present. Combinations of patterns are frequent. Antibodies to double stranded DNA and the so-called Smith antigen are virtually diagnostic of SLE. So these are basically the diagnostic feature of the antibodies in SLE case. Coming to antiphospholipid antibodies. This in itself is a 3 marks question, remember. Okay? Antiphospholipid antibodies are identified in 1/3 of patients with SLE. Okay? So very common. This finding is associated with thromboembolic complications including stroke, pulmonary embolism, deep venous thrombosis, portal vein thrombosis and spontaneous abortions. Etiopathogenesis of SLE. The fundamental defect in SLE is a failure of mechanisms that maintain self-tolerance, although which causes this failure of self-tolerance remains unknown. As is true of most autoimmune diseases, both genetic and environmental factors play a role here. Coming to genetic factors, SLE is a genetically complex disease with contributions from MHC and multiple non-MHC genes. Family members of patients have an increased risk of developing SLE. As many as 20% of clinically unaffected first-degree relatives of SLE patients reveal autoantibodies and other immunoregulatory abnormalities. There is a higher rate of concordance in monozygotic twins when compared with dizygotic twins. Some lupus patients have inherited deficiencies of early complement components such as C2, C4 or C1q. That is, Q is nothing but the long arm. Lack of complement may impair removal of circulating immune complexes by the mononuclear phagocytic system, thus favoring tissue deposition. Genome-wide association studies have identified several genetic loci that may be associated with the disease. Many of these loci encode proteins involved in lymphocytic signaling and interferon responses, both of which may play a role in lupus pathogenesis. Immunologic factors. Failure of self-tolerance in B cells result from defective elimination of self-reactive B cells in the bone marrow or defects in peripheral tolerance mechanisms. CD4 plus helper T cells specific for nucleosomal antigens also escape tolerance and contribute to the production of high affinity pathogenic autoantibodies. TLR engagement by nuclear DNA and RNA. Contained in immune complexes may activate B lymphocytes. These TLRs function normally to sense microbial products including nucleic acids. Thus, B cells specific for nuclear antigens may get second signals from TLRs and may be activated, resulting in increased production of antinuclear autoantibodies. Type 1 interferons play a role in lymphocyte activation in SLE. So here high levels of circulating type 1 interferons and a molecular signature in blood cells suggesting exposure to these cytokines has been reported in SLE patients and correlates with disease severity. Type 1 interferons are antiviral cytokines that are normally produced during innate immune responses to viruses. Other cytokines that may play a role in unregulated B cell activation includes the TNF family member, that is BAFF, which promotes survival of B cells. Now coming to pathogenesis. So such schematic diagrams are very much important here. So potential etiologic factors, the viruses, the hormones, genetic predisposition, that is HLA typing, drugs, that is especially the procannabinoids, loss of tolerance, acquired sensitivity to autoantigens. So such schematic diagrams and flowcharts are very much essential when you approach to an answer for such a question. Autoreactive CD4 plus T cells leading to polyclonal B cell hyperreactivity, which in turn leads to autoantibody production, that is anti-double stranded DNA, immune complex formation in circulation and tissues, leading to tissue injury. So this tissue injury may represent in the form of glomerulonephritis, vasculitis, serositis, arthritis. So this is a flow chart here. In this hypothetical model, susceptibility genes interfere with the maintenance of self-tolerance, and external triggers leads to persistence of nuclear antigens. The result is an antibody response against self-nuclear antigens. So these are the result is an antibody response against self-nuclear antigens, which is amplified by the action of nucleic acids on the dendritic cells and B cells and the production of type 1 interferons, the TLRs, toll-like receptors. So coming to morphologic features of SLE. The morphological changes in SLE are extremely variable. The most characteristic lesions result from immune complex deposition in blood vessels, kidneys, connective tissue and skin. In blood vessels, an acute necrotizing vasculitis involving capillaries, small arteries and arterioles may be present in any tissue. The arthritis is characterized by fibrinoid deposits in the vessel walls. In chronic stages, vessels undergo fibrous thickening with luminal narrowing. Now, renal disease. In particular, glomerulonephritis affects 3/4 of patients with SLE. Immune complexes between DNA and IgG antibodies to double-stranded DNA deposit in glomeruli and lead to various forms of glomerulonephritis. Although glomerulonephritis is the most common renal manifestation of SLE, intestinal nephritis or vasculitis can also be seen. In many of these cases, immunoglobulins and complement are detectable in the interstitium and in renal blood vessels. Skin. Characteristic erythema affects the face along the bridge of the nose and cheeks. The butterfly rash, commonly, once you see this such a butterfly rash on the face of a patient in your OPD, so immediately you can think of SLE and do a antibody test, serum antibodies. So this is a very helpful symptom or the sign that a clinician can appreciate in the patients. 50% of patients, but a similar rash may also be seen on the extremities and the trunk. Urticaria, bullae, maculopapular lesions and ulcerations also occur. Exposure to sunlight incites or accentuates the erythema. So always these patients should use sunscreen lotions and decrease exposure to the sunlight. Histologically, the involved areas show vacuolar degeneration of the basal layer of epidermis. In the dermis, there is variable edema and perivascular inflammation. Vasculitis with fibrinoid necrosis may be prominent. Joints. Joint involvement is typically a non-erosive synovitis with little deformity, which contrasts with rheumatoid arthritis. Serous membranes are commonly involved in SLE. More than one third of patients have pleuritis and pleural effusion. Pericarditis and peritonitis occur but less frequently. Disorders of the respiratory system occurs frequently with clinical manifestations ranging from pleural disease to upper airway and pulmonary parenchymal disease. Pneumonitis is thought to be caused by deposition of immune complexes in alveolar septa and is associated with patchy acute inflammation. Progressive interstitial fibrosis develops in some patients. An increased incidence of pulmonary hypertension has also been reported. Cardiac involvement is often seen in SLE, although congestive heart failure is rare and is usually associated with myocarditis. All layers of the heart may be involved, with pericarditis being the most common finding. Liebman-Sachs endocarditis, which is usually not clinically significant, is characterized by small non-bacterial vegetations on valve leaflets. So these are the Liebman-Sachs endocarditis of the mitral valve in lupus erythematosus. CNS disease can be a life-threatening complications in SLE. Okay, so very dangerous one. Increased morbidity in such cases if associated with such complications. Vasculitis leads to hemorrhage and infarction of the brain, which may sometimes be fatal. Antiphospholipid antibodies are identified in one third of patients with SLE. This finding is associated with thromboembolic complications, including stroke, pulmonary embolism, deep venous thrombosis, portal vein thrombosis, and spontaneous abortions. Other organs and tissues. So, hematoxylin bodies or the LE bodies in the bone marrow or other organs are strongly indicative of SLE. Lymph nodes may be enlarged with hyperplastic follicles or even demonstrate necrotizing lymphadenitis. Clinical features. SLE is a multisystem disease that is highly variable in its clinical presentation, and its diagnosis relies on a constellation of clinical, serologic, and morphologic changes. Typically, the patient is a young woman with some but not necessarily all of the following features: a butterfly rash over the face, fever, pain but no deformity in one or more peripheral joints, feet, ankles, knees, hips, fingers, wrists, elbows, shoulders, pleuritic chest pain and photosensitivity, hematuria, red cell casts, proteinuria. The course of the disease is variable and unpredictable. The disease is characterized by flare-ups and remissions spanning a period of years or even decades. During acute flare-ups, increased formation of immune complexes results in complement activation, often leading to hypocomplementemia. The outcome has improved significantly, and an approximately 90% 5-year and 80% 10 years survival can be expected. So outcome has improved So 80% more than 10 years survival. The most common causes of death are renal failure and intercurrent infections. So this is the most important slide, completely how what's the survival rate in such SLE patients. So today we saw about the how this particular, what are the different criteria, what are the signs, what are the symptoms, the diagnostic importance, what are these LE bodies, system in case of systemic lupus erythematosus. So whenever we do such lab investigation, lab tests to observe for these LE bodies, so what you see basically there is you add some beads in the test tube where there is blood and shake it rigorously so that the nucleus is exposed to the antibodies in the serum, so leading to the binding of these antigen antibody complexes on the cell surface of these particular nuclei, and such opsonized nuclei are being engulfed by the macrophage or the monocyte system, and such cells are stained in the smear, and such are the, so this nucleus surrounded by the nuclear remnants of the engulfing cell like macrophage. And so basically a nucleus being engulfed by a macrophage is an LE body. Okay, why it engulfs? Because of the antigen antibody complexes formed on the cell surface of a damaged nucleus, the nuclear membrane. So such nucleus is being engulfed by the macrophage monocyte or the neutrophil. So such cell is called as an LE body. So the presence of LE body is a diagnostic criteria in such cases. So important is the anti-nuclear antibodies. So all these antibodies presence the biochemical assays reveal, and hence a diagnosis of SLE can be made. So thank you students. Here we conclude this session of SLE in pathology. See you all in next class. Goodbye.